The largest healthcare infrastructure in Africa was not built by a government. It was not funded by an international NGO. It was not designed by a public health agency. It was built by faith, brick by brick, community by community, over centuries. The church, the faith community, on day 23 of documenting my rise as a global health and wealth architect, I want to make a case that I believe could fundamentally change how we think about healthcare delivery in Africa and Brazil. The faith community is not a supplement to the health system. It is the foundation the health system was always supposed to be built upon. What the faith community already does for health. Let me paint the picture as it actually exists, not as we wish it did. In sub-Saharan Africa, the church and the mosque reach communities that no government health program has ever consistently served. They have buildings in every village. They have trusted leaders in every neighborhood. They have weekly gatherings of people who would never voluntarily walk into a government clinic. They know when a family is struggling, when a mother has not been eating, when a young man has withdrawn from community, when a child has missed school because of illness that nobody has addressed. Faith communities are already doing informal health work without training, without resources, without clinical protocols, simply because they are present in ways that formal health systems are not. The question is not whether faith communities should be involved in health. They already are. The question is whether we will formalize that involvement with the training, the resources, and the clinical partnerships that would make it dramatically more effective. What a faith-funded clinic actually looks like. Let me describe the model I am envisioning, concretely and practically. Not a hospital, not a government facility, not a charity clinic dependent on international funding. A faith-funded primary care practice embedded within a faith community, sustainable, professional, and deeply trusted. The structure: a DPC practice formally established within or adjacent to a church. The faith community provides the land and the building, assets they already own and that sit unused for most of the week. The physician provides the clinical expertise, practicing DPC principles, continuous relationship-based preventive primary care. The pastor becomes a formal health advocate, not a medical practitioner, but a trusted bridge between the clinical team and the congregation. The funding model. Congregation members pay an affordable monthly membership, collected through the same mechanisms already used for tithes and offerings: mobile money, cash envelopes, digital giving platforms. A portion of the congregation's existing giving can be directed toward the health fund, making the clinic a collective act of community stewardship rather than an individual expense. The clinical scope: primary care consultations, preventive health screening, maternal and child health, chronic disease management, mental health support, working in genuine partnership with pastoral counseling, referral pathways to specialist care when needed, the community integration, Sunday health talks, Friday health education after prayers, health screening days after major religious gatherings. The faith calendar becomes a health calendar. Why this model works where others have failed. Every serious global health professional has seen this pattern: a brilliant health program, well designed, well funded, launched with great fanfare, and then 3 years later, quietly abandoned, because the community never trusted it, never owned it, never integrated it into the fabric of their lives. Faith community healthcare partnerships succeed where external programs fail for one fundamental reason: trust. The pastor who tells his congregation that the clinic next door can be trusted, and who means it, because he helped build it, because his family uses it, because the doctor worships alongside the congregation. That pastor has more health influence than any government campaign ever printed. Faith gives the health message an authority that clinical credentials alone cannot provide. And in communities where health systems have repeatedly disappointed, failed, and abandoned, that authority is the difference between a program that is used and one that is ignored. What I am building and what I am asking. This vision is not theoretical. It is the next layer of what I am constructing, brick by brick, across this journey. The DPC network I described on day 22 is the clinical foundation. The faith community partnership is the community infrastructure that makes that network genuinely accessible, genuinely trusted, genuinely sustainable, in ways that clinics operating in isolation can never fully achieve. I am asking 3 things from the people watching this. If you are a faith leader, a pastor, a priest, a deacon, a women's ministry leader, ask yourself this week whether your faith community's physical and relational assets could be deployed for the health of your congregation and your surrounding community. You do not need a medical degree to initiate this conversation. You need the conviction that health is a stewardship responsibility and the courage to act on that conviction. If you are a health professional, a doctor, nurse, community health worker, or public health professional, find one faith leader in your community this week. Have a conversation. Build a relationship. That relationship is the beginning of the infrastructure that changes your community's health permanently. And if you are a young person watching this, building your career, building your faith, building your vision, know that the most powerful institutions are always built at the intersection of things that most people keep separate: health and faith, clinic and community, clinical expertise and communal trust. That intersection is exactly where I am building, and I am inviting you to build there with me. If this opened a new way of seeing faith and healthcare, share it with one faith leader and one health professional in your network. Subscribe. Comment below. Does your faith community have any health programs? What does it look like? I want to hear from every country in the comments.